and for a variety of reasons, that's true. If we can go to the next slide. Let's see. I got a little mess. Okay, got it. It was just telling me the message is this is being recorded, which is fine. And again, I'll draw attention, obviously, to a couple things on here. The Higbee commissioning in 44, as we flip to the next slide, I think, one of the things that Admiral Keener was so very proud about, and rightly so, is being one of the keynote speakers at the commissioning of the Higbee this past spring. And I think, that recognition of the importance of the Nurse Corps shouldn't be understated. And it's really an interesting thing. Now, as you're looking at the rest of the bullets on this slide, one thing I think, there's a lot of firsts listed on there. And when we go to the slide I have, I think and we talk about our present, I want you to look at the number of CNOs, PXOs, PCOs, and COs and XOs from the Nurse Corps we currently have there, because we have made immense strides in leadership in that realm, and none of that occurs without the work that others did in paving the way for us currently. So that's really the take-home message there for me. But if we could go to the next slide, and then the next one. I do want to anchor on this slide just a skosh. I talked a little bit about the COs, PXCOs, and really what's intriguing to me is the PXOs on here, because those will become PCOs the next in 2 years, right? And so that's a pretty good number. And I'm very proud of the Corps for that. But I also want to anchor a little bit on, our current manpower situation. And, there's a variety of reasons that 86% how we got here, without going into details too much, but, one point I would make is we operate in the Navy Nurse Corps in the larger microcosm of the health system. And we're all well aware, coming out of COVID, of the stresses and strains on the greater health system writ large. And so it would be naive to think that doesn't affect us. Of course it does. Likewise, while we did not have divestiture cuts, just to be clear, those cuts were turned off. Had they gone into effect, it would have cut the Nurse Corps fairly substantially. Those have been turned off, but as you guys are well aware, in our DOTMA status is that, when those divestiture cuts were planned, although put on pause and not executed, we had to turn down the pipeline several years ago. And we really didn't have a choice at the time. And once you turn that pipeline that goes into, as I would term it, the sessions, and the force shaping that requires that, there's going to be a couple year period where we're going to have a manpower shortage rolling through the system, frankly. And we can overcome that. We can mitigate it. And I do, not just to be a glass half full, I believe we'll achieve it, but it poses challenges. And so, now, and one of the questions I know, and I'll talk a little bit of specifics of the questions I had that's not on the slide, but there was some questions on, the CRNA manning. Right now, as of last month, we're at about 87% manned in CRNAs. You think of our greatest needs within the operational setting, and one of those is in the critical care nursing, and we're at, around 75% there. So, those were specific questions that were fielded here. I figure I would answer those. we do think, and of course, predicting these things and the future trends is always a challenge, as many of you are well aware. We do think we're staving off the drop, which is good. A couple of key things I want to talk about that we're doing to get after, our manpower. There's two levers, as you're well aware. One is the sessions, the other is retention, and they work together, and we need both. So we're, some of the initiatives that we're doing to increase the sessions. We are also returned back on the pipeline of the sessions. And give you an example, our ROTC scholarships over the last decade or so, it shrunk to about 10 per year. We have authorization now to up that to 100 over a couple year period. So one of your asks is, what can you do to help? Certainly, if you happen to be talking in high schools or anywhere, or people that are early in their college years, point them towards the Navy recruiting office and remind them that the NROTC scholarship may be an opportunity that is, it's a good time to take it, because we have more numbers of those. And as many of you are aware, the line has to give those up. So they've, on a positive note, there is a recognition across the Navy that the importance of the nurse corps and the fact that we need to have those accession pipelines. Obviously medical enlisted commissioning programs, Stay 21, all those things are viable. We need to, and we're upping the input in there as much as we can as well, to try to drive that accession into the corps. Retention wise, some of the things we're looking at, and you can't, we all recognize you just don't throw money at things. It's not always what's actually keeps people in, but we are looking to make sure that we don't put artificial barriers to getting things like retention bonuses and certification bonuses. And we've upped, in some cases, the amounts in areas where we need. And we continue to look with the mantra to remove any unnecessary barriers. Where there's statute barriers or policy barriers, we either change the policy or do exceptions to policies. One of those areas that I can think of was in the accession bonus and having to already be certified and licensed before you get the accession bonus. And so we're working through some policy issues, because frankly, if you're coming in this market and you get told, yeah, you got to wait, that's probably not a good model, right? I mean, there's the salaries in the civilian world have increased. Now you can argue whether those are sustainable, and many of you are in that field and you know that better than I, but let's just say we're competing. And so, we have to reduce any barriers to that, and we're looking very hard at that. And I know many of you have gone before, have done likewise. So it's not that that's some new thing that we're trying to do, but we really are deliberately trying to take a look at ways and levers. And I over the next year or so, I am going to have my eye on the ball pretty deliberately to make sure that the things that we are doing, and if you look, when we get to our strategic plan, some of those things are in there. Just, they may seem quite tactical, but we do need those things to be able to actually, make sure that we have a viable nurse corps for the out years. And so I think we'll get there. I certainly welcome any help in recruiting and anything you can do on that. That always appreciate. It's like I had an all hands call a few weeks back with the nurse corps, and I said two things. One, you're all important. And I'm going to say something that kind of bothered me as I was coming up, and I'm a nurse anesthetist, so it's not, but we were using these terms of critical wartime specialties. And quite frankly, and it's Bob's opinion, I don't think that those are particularly helpful distinctions, because the fact of the matter is we need every nurse in uniform that we have. We map them against deployable platforms now, and I can promise you we need them all. And we need specialists in every area. And so to create an artificial distinction is demotivating for an entire, group. So I said, so you're important. Each of you are important. So that was one thing I said, and I meant it. The other thing is, how each of us in active duty who wear the uniform are recruiters, and I do encourage people to be advocates, being out into the communities. The Bureau of Medicine and Surgery has started a speakers bureau with the Surgeon General's initiative to really, because it's not unique to the nurse corps, frankly. It's true in the medical corps, it's true in the hospital corps, it's true essentially in all corps in various degrees. So, it is all of our business to be advocates in that way. And so, I think that's important to say. So, let's go ahead and I'm not talking about the reserve numbers. Eric and I are locked at the hip and working together, and we're frequently in communication. The reserves have done a yeoman's work in mapping against expeditionary platforms for us. We don't get to where we need to be in the deployed setting with our expeditionary platforms, whether they be EMS, ERCS, ERSSs, EMFs, the hospital ships and the CRTSs without the reserve force. They're deeply integrated into our processes, and from a manpower standpoint, we know that we need them, and so we are locked at the hip. We'll go to the next slide. And I'll talk a little bit about this, although primarily there's obviously been a rise in doctoral education, in particular within the advanced practice setting. So none of this is really shocking, and I think that trend is going to continue, frankly, especially in the obviously nurse anesthetists for entry into practice now have to be at the doctoral level. The other advanced practice roles, while not mandated for the most part, in many cases, that's although there's still room for masters too, for a variety of economic and choice reasons, but I think that trend's only going to continue. The part that's an interesting phenomenon, I think that we need to think about, and I've asked the team to just consider it, is our entry to practice for nursing is still the baccalaureate degree, and that's not going to tectonically change, but the things around us are, and as many of you are well, there are many master's entry to practice programs that are pretty prevalent in some places. So making sure that we account for that is probably an important thing for us to do. But again, it's not that we are looking to change the entry to nursing practice away from the baccalaureate degree. That's not true. We just have to recognize the context of the educational system and the rise of general entry or master's entry. And many times, as you're all well aware, I think those were designed on the realization that many nurses went back for their bachelor's degree in nursing when they had a bachelor's degree in another field. And so they're trying to meet a market need, to have people come out and their entry to practice degree with a master's degree. So we just have to look at the policies to make sure that we're not hindering entry, but there's no effort to change the entry requirement for baccalaureate to the master's or anything like that. That would be at this stage would not be something that we really need to do. We really just need to make sure that we have the right. We don't have hindrances to entry to practice, I guess is the best way I would put that. One of the key questions I think you have is, as the rise of the DMP, what is the impact of that on the PhD? And if you look at the numbers in the civilian sector, you will see a trailing off of the rate of rise of PhD nurses. While the raw numbers, I think, are still high, but I do think there will remain a need for PhD nursing, even with the rise of the DMP, certainly within the Navy. One of the things, talk a little bit about the Tri-Service Nursing Research Program for fiscal year 24. 13 million were set against the highest priorities in operational nursing, things like expectant casualty care. That includes around 8 million in actual grant awarding. So there, and I believe the TSNRP was a line item in the NDA for, so that is a good thing. I do think there is a need. There's a need both in the creation of new research. There's also in the evidence-based practice space room for translation projects. There's a mixture of those projects within the funding of TSNRP, and as certainly other prior Corps chiefs on the line know, and many of the deputies know, obviously we are integral to the Tri-Service Nursing Research in terms of the executive board, which is good. And so, one of the things I think one of the questions were, and I will tell you, I'm trying to consider how, as many of you know, during wartime, we rapidly recognize we need data. We need people that think that way. We need people that analyze it. We have deployed research teams in combat. What we don't have, at least in my opinion, that's something I'm trying to think about how to do, is a built-in, no kidding requirement that we lay against in the operational setting for research. We don't really have that. We have touches of it. If you look in the joint trauma system, there's aspects where you would need that. But we probably, one of the things I'm thinking about, in some of the PhDs who are on active duty still have asked me, how can we, codify and solidify the requirements. So, because as you know, you have to have that bona fide requirement. Then the decision whether that's a funded requirement becomes. Now we have manpower. We do have requirements for PhD. They're on our manpower documents, but I'm really talking more about hardwiring those into the utilization of them in combat, for example. So that's what I'm thinking. We'll see how that goes. With that, let's go to the next slide. Now, there was a question on COVID. Obviously, I was in command of public health through the pandemic. I might have PTSD. Tongue in cheek on that. I don't want to patronize or belittle that, but it was one of the things I think that is a key lesson that maybe one of the questions was getting at this, that Navy medicine learned. It's just how. Let me go back. In wartime, we know non-disease battle injury many times takes more casualties than the actual war itself. Of course, it depends on the kinetics of the war and so forth, and whether you have superiority and those kinds of things. But suffice it to say, in wartime, non-disease battle injuries, of which disease would be one of those, right? Having infectious diseases could be included into that category, are important to think about. And we think about them once there's a problem. We're not very good humans, I think, in general, about the avoidance of bad outcomes proactively. And so I do think there's been a lot of lessons learned that when you're faced with something like a pandemic, that you didn't think was going to come, that you didn't predict, and that you saw the upheaval, that there's a focus on those kinds of things. But that focus won't remain if we're not deliberate about it. So that's just a kind of a thought pattern I have. A related thought pattern, and if you look at the COVID missions, we were all, and many of you were in at the time, know that we were out into the community. We were in the operational setting, deployed nurses. We were in the civilian care system, supporting the system. And we learned something, that perhaps the system didn't have the capacity in certain areas that we thought it might have. And so we were actually augmenting that, right? That's pretty interesting. It's not something that I would have intuitively, frankly, known. I wouldn't have thought it. I would have probably said the opposite. But in fact, the Nurse Corps, really did deploy. The next slide, if we go to that, talks about last year's deployment. About 7% of the Nurse Corps was deployed. You can see it by specialty. But I want to draw you to, I'll leave this on there for a second, but then I want to shift to the next slide, because I want to draw some attention to you that gets back at what I was talking about during COVID. And so you can look at the Nurse Corps during COVID, and it was like 22%. That's a lot at any one time, right? Again, Nurse Corps highly utilized in deployments, in steady state, certainly in extremis, a huge need. That's really the take home. And there is a recognition within the rest of the medical specialties and the line of the importance of nursing. There was a question, I'll get to it here because it's not exactly, doesn't fit in anywhere else, about the aircraft carriers and whether they're PCS nurse anesthetists. The answer to that is yes. That's been over the last year. As many of you know, it's back to the future, back and forth on that with TAD for times. Then we're permanent ships company. Right now, it's back to permanent ship company for the nurse anesthetist on the aircraft carriers. So I know somebody had a specific question on that, but that relates more to the baseline operational footprint for nursing than anything else. Let's go to the next slide. So, as we think through strategy, we're using, and I talk about it in a few minutes on the get real, get better mantra, but we're really trying to, as rationally as we can, connect a problem to a solution, and not reverse it, the solution looking for a problem. So, that's intuitive. We all know it, but that's all we're trying to do between readiness, recruitment, retention, resilience. I would argue resilience anchors all of these. If you do not have a resilient workforce, if you do not have a resilient Nurse Corps, you're not going to retain the best and the brightest, and you're not going to be ready. So I see the resilience initiative as a enabler, really, of those other two strategic goals. We are deliberately, I talked about the recruitment and retention. We're trying to go after those things deliberately with accessions issues. We are trying to do selective retention mechanisms, or even, we're looking, some of it's pre-decisional, so I'm not going to mention them, but we are deliberately trying to do this, and there is a willingness, certainly within Navy medicine, to support this. There's also a support outside of Navy medicine. I presented at a flag forum. It's basically, it's called the Felix course. And it's really what it is talking about the get real, get better, and how you develop a canvas to address problems systematically. And I actually, the Nurse Corps retention recruitment was included in the week that I was there, which I was kind of thrilled about, because I got a bunch of, line folks, flags, 1 stars and 2 stars, to hear some of those things that were going, and then get an understanding of the challenges we have. And I'm not, I was, frankly, I thought it was good that we were able to do that. And it was helpful to me because you get a different perspective to think about things. We had people in there with a lot of experience in recruiting, just as an example, and just having conversations. And so the resilience, one of the things that part of resilience is cultural, and I mean that in a way that enables people to be empowered to bring up issues, to make changes, and not to have toxic leadership in the way. And one of the things, and it starts at the top and it goes all the way down. But we want a culture that supports that resilient workforce, because there's challenges at the deck plates. There just is. And one of my things that I'm going to start doing is I have an all hands call, but you get partial truths in that, don't you? You get some truth, it's good, but you really got to get out and about to figure out what is actually what's the pebble in the sandal that's really rubbing people. So I need to get out a little bit and do that, and that's my plan to do that. But in my words, as the chief director of the Corps, I am trying to empower people to remove barriers, to remove those at the right level, to elevate concerns that and not die in, suffer in silence. And that's probably the biggest thing that we're trying to do. And we got, we've done some surveys to try to figure out what any issues are, but it's really the leadership engagement in all levels that is going to be the most impactful, frankly, in any of these strategic goals. So, okay. Next slide. Now I've talked about a lot of these, but I'll go over them again. Some of my, so next slide, please. Yeah, there's challenges. I talked about it early on. We exist in the larger microcosm of the healthcare system, which has issues, right? Contributory, sure they are. We're looking to optimize our force structure to meet our needs. Surgeon General last year started a campaign order. I was the Director of Maritime Operations when that kicked off at BUMED. And we're really trying to align our priorities to our capabilities. In other words, our deployable platforms. What are the knowledge, skills, and abilities needed to do that? What's the certification of those units? Do we forward deploy some of those? And I watch classification here, but those, and then there's some of those problems, we're palming those in. We're looking at the sustainment of those deliberately within the POM cycle, right? And then we have to get those KSAs. The MTF is the primary training platform still, and should be. Where are the gaps in that? What can we do to mitigate those? And how can we potentially, within the direct care system, begin to pull some of that in? I won't get into too much of that but it is a recognition that we exist in this system, and then where there are staffing shortages, for example, within the healthcare system, there's impacts to those. And so how do we both monitor those, try to support them, and shore them up, right? But those are not simple things. They're complex, and you guys know that well, I think. Next slide. And opportunities. While there are challenges, there are also a lot of opportunities. And the military health system is being driven very directly and deliberately towards stabilization. and modernization. Those things will pay benefits. And from my view and lane, it's a positive direction. There are also opportunities within the Nurse Corps directly that we have the ability to impact. I personally would like to see more pathways in place, whether that's from initial entry to practice in nursing to advanced practice to the operational setting, or whether it's from initial entry to practice as a nurse through whatever specialty the particular individual wants to be practice in, having those hardwired pathways. Can we do I-stops for things like the critical care course, the labor and delivery course? Can we, can we segregate things in a way that we establish a pathway, we provide a educational opportunity, and they don't all have to be degree opportunities. And that's kind of my point there. While we've done that periodically over time, I think that there's a lot of opportunity to be able to hardwire those pathways and then to connect into the operational setting, whether that's at the advanced practice, F&P level, or, CHIPS nurse, whatever, or flight nurse, because the ERCSs now have a one critical care nurse, or probably could also be ER. We're working through some of the competencies on that. But basically, bottom line up front, we want to support all nurses in the Nurse Corps practicing the fullest extent of licensure, and if they have certification. So licensure and certification as appropriate. Part of the way you do that is having pathways that establish a real rigorous expansion of scope of practice when appropriate, for example. That's just one way, and that's how I tend to think about it. Mental health, I didn't actually, let me pull up my screen. I was gonna, mental health nurse practitioners, just as an example, I think we're around 50% man. Now, part of that's because we've increased the requirement. Some of our sprint teams, now that we increased the total number of sprint teams by like 10, if you start increasing 10, my point there is part of that's been the demand is increased, but and certainly in the civilian sector, the demand is also high. So, there's a lot of opportunities there to grow from within, but that is also could also have been on the challenge slide, I suppose. Okay, next slide. And so Navy last year, I think it was sometime under Admiral Gilday and Admiral Franchetti has followed suit. And if I was to sum up the get real, get better, I've talked about a lot of this in my talks on the leadership during this talk. But we have to have transparency. People have to be able to bring up problems, and then we have to systematically find the levers that actually address the problem. And this is common sense. This is repackaged things that we've always known. It's not rocket science, but really what it is inculcating a culture. And that's real. That's why I use that term, because and it's probably, whether it's the correct term or not, I don't know. But what I'm getting at is it's how you do the day-to-day business of healthcare in our case, but in the Navy at large, how we do operations. How do we, it is a culture of safety. It is a culture that doesn't hide problems but brings and bubbles them up. It's the leadership that has to remain engaged, because this does not work. It's not a program. It's not a slogan. It's not because it doesn't work or works when how sustainable leadership engages to encourage that kind of behavior that builds trust. And it's simple mindset. And I will say my opinion is in the last couple of years, I've seen a lot of improvement, but it is not an end state. It's a way. It shouldn't be check, we're done, we got this. In fact, I would argue would be a symptom that we don't have it. It is a way. It's always, it's every day. What can I do to make it better? What's the actual problem? What solutions can be done? Where do I have gaps in solution? What are the resources needed? Okay, if I don't have the resources, what risk do I now have? And does everybody understand that risk? So that's kind of where we're going. I hope that I've at least addressed many of your thoughts. Trying to go through the questions to see if there's something I can talked about the nurse scientist a little bit. Oh, this is an interesting one, and I think it's a great question. Were the billets for obstetrics, pediatrics, and family practice ever adjusted to reflect the number of women on active duty remaining for their career? It's funny that it's not funny, haha. But I was just talking about this issue with the deputy corps chief, Allison, and I have it always begs a question. Full disclosure: one of my daughters is a Navy 60 Romeo pilot. She just put on lieutenant commander. And I'm thinking to myself, the equipment wasn't designed for her, right? We all know that. Let's just be honest. What are the health implications of that? What are the women's health specific things? And she's now deployed on a carrier right now. So I think the short answer is we gotta push this a little bit, and I actually don't know the answer. In other words, I don't know if we need more or not. I have which I can take for action to think about, but the fact that I don't know makes me think, and then I look at my anecdotal thought pattern with the ever increasing number of female Navy personnel that I don't have a hard time thinking there may be an issue. And so we probably need to think about that, and I'll take that offline for action. But I think it's an excellent question. And in many regards, it's something that we should think about as our force structure changes, whatever that is, whether it's upsize, right, down, low size, different mixture of gender, what have you, whatever it happens to be. We probably should reflect and ask the question, okay, is our force structure in support match that requirement, right? So I think that's an excellent question. Okay. I don't know. Do we? That's all my prepared remarks that I had to go over. I do hope you found it helpful. I don't, but I'll turn it over to the team here.
Okay, I'm unmuted now. Sorry. Sharing your screen really ties things up. I think I'm going to refer it. I don't want to punt to Cindy Sweeney, but I know Cindy, as our NNCA president, may have some things she wants to say in follow-up. But we really enjoyed hearing about what's current. Cindy, I'm going to opt to you now.
Thank you, Chris, and a special thank you to you, sir, Admiral. Truly enjoyed your presentation and bringing us up to date with where our Corps is today. A couple of things struck me, if you don't mind. I'm just it's a statement rather than a question, but one of the first things that occurred to me as I was listening to your presentation and in the last few slides, when I was a brand new ensign at OIS, we had to write an essay about leadership in the Navy. And I, had just finished up my degree at the University of Maryland, and I had learned all about the nursing process. And with that, I wrote my essay on leadership with the background of the nursing process. And I think all of us on today know what that means, right? Assessment, planning, implementation, evaluation. Of course, they've added on some other letters throughout time. So it struck me that the whole idea of assessing and making a plan, et cetera, it's ingrained in our core. And I say that to say, when I wrote my essay, my line officer lieutenant took me aside and he really wanted to talk to me about this. It was like an aha moment for him. He hadn't even thought about it. So I think the Nurse Corps has an awful lot to teach the line, and I'm married to a line officer, retired. So I've been teaching him a lot for many years now. But I open that for a comment if anyone else has anything to add. But I think we've kind of led our lives that way with going into any situation with the idea that we assess and come up with a plan, implement it, and then we go back and evaluate continually.
Yeah, I think that's spot on. And I would, one thing I didn't say, and I like this term, and hopefully it boils down to the rigorous, and I didn't make this up, just for the record, I heard it and I stole it. It's the rigorous application of common sense, right? Connect, know what the problem is, connect the solution, the activities you do to solve the problem to the solution, right? And we know it. So the value in this is reminding ourselves, maybe daily, of that, right? If we were to do that across the Navy, which I think is actually the point of the Get Real, Get Better, everybody understands it's not a program. Although that's why I use the term. It works. It doesn't work only as much as we adopt and how we do the business, right? So, I think that's spot on. Over.
Thank you. So one other comment was on the resilience piece, because we know across nursing in general, resilience is a real point, a real focus for everyone that is in a position of leadership for nursing. And, we know that resilience can be fueled in many, many ways. And my background, having worked at the Daisy Foundation, of course, is about meaningful recognition. And I think part of in the Corps, we have that almost ingrained. We get recognitions through medals, through promotions, et cetera, that the nurse in civilian practice may or may not have. But I've been very happy to see the numbers of Daisy awards that have gone out through the Navy facilities, as well as Army, Air Force. So I think we've got some fuel that, we can power that resilience with in many ways. So.
Yeah, I do think that's, and I am interested as I get out and about to see, other ways that we can strengthen it. I do think you're right. Sometimes it's the smallest of things. That it's not small. I don't mean it like little. I just, it doesn't take much sometimes. And that's, if you do that, you have an impact, and it's like, one of the things when I do talks too, and it's along the same lines, it's like I let off the nurse call telling people they're important. I wasn't trying to be patronizing. I meant it. And the other point of that is reminding people. It's not wrong to remind them in a kindly and a motivating way of why they're wearing the uniform. Because I can tell you in the day-to-day muck, and I've been there, you forget. It's sometimes helpful when leadership in a positive way reminds us all why we're here, right? And then if someone says, yeah, but you're not enabling me to do that, that's where back to the assess and then define the problem and remove the barrier, fill in the blank of the rest and solve the problem goes. But you have that initial conversation where we are motivating ourselves. I mean, every time I say that, and I even say this a lot of times. I say, look, I'm talking to you, but I'm also talking to me. I'm reminding myself of why I'm still in the uniform. And
okay.
Oh, did we lose you?
Okay. We lose you?
Oh, I think we're losing you.
Okay.
Yeah. Admiral, I think we've lost your audio.
Oh, can you hear me
Oh,
now?
now we can hear you. Yes,
That's
thank you,
better.
sir.
No, I
Okay.
don't know. It's probably just as well I was rambling on. I don't know. I don't know what everybody heard, but basically I was just saying that the leadership engagement and the reminder of why we're in the uniform is also connected to recognition of people's hard work. Over.
Absolutely. Absolutely. Well, I certainly want to thank you and recognize all the efforts that you're doing on behalf of the Nurse Corps, a place where I felt like my roots were planted, and now a long, long history has passed. And I think many of us on the screens today feel the same way, that, once a Navy nurse, always a Navy nurse. We learned so many lessons from our young years into our older years, and are always happy to pass some of that wisdom along in whatever way seems amenable to the Corps. So with that, I'd like to thank everyone for coming today, and especially you, Admiral, and we'll look forward to hopefully having some more presentations. So if anyone has ideas on things they'd like to hear, please let us know. And just remember, we have a brand new website now. I encourage you all to go to nnca.org. A lot of hard work has gone into it, and I think you'll enjoy it. It's just a great way to pass some time. And we also have a reunion coming up, so I have to put that plug in there. Anyone that is interested, we can still take you. I'm looking forward to seeing many of you on board. We're going to do the fall cruise in September. So, Christine, anything you'd like to add?
Well, I was just going to, I did have a comment from Rebecca McCormick Boyle, and I don't know, most of you know Rebecca is a prior Nurse Corps director, so it's probably deja vu, Rebecca. And I think you had a question you wanted to ask Admiral Hawkins, and I'll let you ask a question.
Well, thanks. So, Admiral Hawkins, thank you so much for taking the time with us all. I had a question as a person who has now been out in the community several years after we put that restriction on recruitment. We said only nurses with a year or more experience could come into the Navy. Do you remember that period of time? Not so long ago.
Yep. We're
And
trying.
so, yeah, and so I say that because this is my hometown, and I've always been very active with the recruiters here. In fact, I had lunch with two of them today. But my point being this, since I've been home 3 years, I have identified with them, they have lost their connection with the schools. So in that window that they couldn't recruit from the schools, appropriately so, I'm not blaming the recruiters, they turned away from the universities and they went where they needed to go to recruit. And so I'm just, the question is, do we have an effort to regain that relationship with university professors in the schools, so that as young men and women are thinking about where they're going to go when they graduate, they see the Navy as an opportunity?
Yeah, that's a great question. And the short answer is yes. Part of the reason for the Speaker Bureau is to try to get after that. And I don't, and the other thing, we just need to, and I need to do it, but more importantly, we need to get, I'm going to, I may not be the greatest poster child to enter Navy nursing if you're 20 years old. We need to, as part of that Speakers Bureau, having people that are ensigns, lieutenant JGs that are out, that perhaps look more like, so yes, it would fall under the recruitment and retention strategic goal. The good news is we recognize the gap, as you articulated well. We just have to execute it, and be deliberate. So I will continue to do that, because I think that's actually where our biggest bang for the buck is, quite frankly. It's in the relationship building, and the muscle memory that we have to communicate message and opportunities.
Yeah, we had really, I think all of us, I'm sure on this line, there's many people who were recruiters, we were tight with those professors, and the gentlemen I work with today, great guys, but they have no relationships with the university. And surprisingly to me, they didn't, they thought the University of Buffalo was the big draw, and it's not the biggest school in the area. There's 3 other schools bigger. So it's just, and their line leaders don't know that. Their
Yeah.
line leaders don't know that. So just a comment. So again, thank you so much.
And Rebecca, that was a great question, because that kind of dovetails into a lot of what NNCA does and is able to do. Many of our chapters have very active scholarship programs. And as recently as last week, Cindy Sweeney and I were talking on a separate issue, and she had been at University of Maryland and interacting with folks there, and realized, oh, they haven't been really with the Army. The Army right now is very engaged with University of Maryland, and not as much so with the Navy, but I think that might change soon.
Yeah.
So that's
I'm on the alumni council at the University of Maryland, and had an opportunity to talk with the dean and that group that I serve with, and just mentioned I had been a Nurse Corps candidate and felt very isolated, and what were we doing to reach out and kind of show some love. And so it was an eye opener for both, because it's a win-win. They want to have a relationship with us because we have a source to bring other colleagues into their university, and by the same token, we have an opportunity to bring them into the Nurse Corps. So I think there's lots of opportunities. Everyone here on the screen should go back to their universities or where they got their degrees and have a chat.
May I just say hello to Admiral Hawkins? My name is Christy Sierra. We were MECP students together at the Medical University in Charleston.
Good to see you, Christy. Yeah.
It's great to see you too. I remember, I'm like, oh my gosh, I remembered you weren't a corpsman, that you were a nuke, but I didn't realize you were on the Stimson. My former husband was on the Stimson, the Blue Crew.
That was cool.
Oh,
yeah.
Those were
Small
fun
world.
days. And thank you for representing us Mustangs.
Oh, absolutely. Good to see you too.
Yes, I giggle because you and Chief Ricky Ruffin would giggle at me, because my junior year, I was in the LP and the BSN program, and I hadn't been selected for MECP yet. And I'd be in my uniform because after class, I'd go work at the brig. And y'all would giggle at me, and I'd giggle back and say, yeah, you can giggle at me, but I'm using tuition assistance. You got to pay your own way.
Oh, I forgot about that. Yeah.
Very proud of your accomplishments. That's wonderful. What a great mentor you are.
Well, thank you.
Thank you.
Have a wonderful day.
You too.
There was 2 other questions in the chat. We didn't get to Odette's question, but that was really in an area that Admiral Hawkins was not going to address, and that was about military health care. Today's presentation was strictly on nursing. And I believe the other question relating to systems, what do we have now, what kind of electronic record, was answered in the chat.
Yeah, it's MHS Genesis, which is a Cerner product. Yep.
And I think that's probably about it. We really appreciate your time. And again, our NNCA is an organization. Again, we're a nonprofit veterans-focused organization. As you can hear, we're out there to help with recruiting. We sponsor many of our chapters sponsor Daisy Awards, and so we're out there helping out with things as much as we can.
Yeah, I do want to thank you, each of you, for that. As I was that's a force multiplier, and so I certainly from my heart appreciate the efforts, and I know it's with the core purpose of supporting the Nurse Corps, and so thank you.
Okay, great. So I think that's
pleasure.
probably all the general questions. And I think that we've done pretty well to just under an hour presentation. We probably can stop the recording, Dot, if you haven't already.
Mm-hmm.
I had a little learn something.